Good morning everyone. I am Dr. Prashant Kumbhaj, Associate Professor in the Department of Medical Oncology. Colon cancer is cancer. The cases are increasing day by day, and if we see the incidence in Western countries as well as in India, so we see that the incidences are increasing. And the molecular pathology, if we see the molecular pathology, so we can find out the mutations that is responsible for this disease. So today we will discuss about the mutations and molecular biology of the colon cancer. So chromosomal instability is a feature of up to 80% of colorectal cancer, and it is commonly associated with the activating KRAS point mutation, and that is the most important mutation that is found in colon cancer, and loss of region that encompass P53 and other tumor suppressor on 18q and 17p chromosomes. So the genetic pathway which causes colon cancer. So all colon cancer arises from within benign adenomatous precursors fielded with mutation that serially enhances malignant behavior of the tumor. Mutations that activate the Wnt signaling pathway seem to be necessary initiating event, after which two possible courses contribute to the accumulation of the other additional mutations to cause colon cancer. So if we see or if we talk about Wnt signaling pathway, this is the key driver pathway that causes colorectal cancer. Member of the Wnt signaling family of glycoprotein morphogens bind to the cell surface receptor Fzd and LRP56. In the absence of Wnt binding, normal cells use a complex containing APC, exin, and other cytoplasmic proteins to promote GSK3 beta mediated phosphorylation. So this is the picture where we can see how this Wnt signaling pathway is activated and how this signaling pathway goes downwards towards nucleus, and how this pathway causes transcription of targeted genes. So Wnt signaling pathway started with membrane receptor, and it goes through exin, APC, beta catenin, and it goes to nucleus where beta catenin is causes transcription of targeted gene like c-Myc, cyclin D1. And this is the pathway where the ligand unites with the transmembrane receptor tyrosine kinase, and it causes downstream signaling, and the signaling of this tumor goes downwards through RAS, RAF, MEK, MA, PK, and this causes cell cycle progression and proliferation. So if we see what are the common mutations that are responsible for colorectal cancer in human, so the the oncogenes are KRAS is 35 to 40%, PIK3CA is 18 to 20%, BRAF is 7 to 15%, NRAS is 9%, ERB B3 8%, CTNN B1 5%. That are the oncogenes which are responsible for colorectal cancer. Tumor suppressor genes that are the mutation of these genes causes colon cancer. So most common is APC, that is 85% cases, T53 in 50% of the cases, SMAD4 in 10% cases, FBXW7 is in 10% cases, SOX9 in 5% cases, and some other epigenetic modifier genes, ARID1A, SYN3A, SMAR, CA5, NCOR1, TET1, 2, 3. So about 20% of colorectal cancers are euploid but defective in DNA mismatch repair, resulting in high microsatellite instability, MSI high, and this MMR defect may develop sporadically associated with CpG island methylation or as a result of familial predisposition in hereditary non-polyposis colorectal cancer. And these mutations accumulate in the KRAS or BRAF oncogenes, and P53 tumor suppressor and in microsatellite containing genes vulnerable to MMR defects such as TGF beta R. And if we talk about the epigenetic changes which are responsible for colorectal cancer, so epigenetic inactivation of MMR gene MLH1 and activating BRAF point mutations are especially common in serrated adenomas, which progress in part through the silencing of tumor suppressor gene by promoter hypermethylation. And the progression from adenoma to CRC takes years to decades, a process that accelerates in the presence of MMR defects. So if we talk about familial adenomatous polyposis, so this is constitute 1% of all the CRC cancers. And hallmark feature of this syndrome is hundreds to thousands of colonic polyp that develop in patients in their teens to in their 30s. And if the colon is not surgically removed, 100% chances of progression to colorectal cancer is there. Second one is hereditary non-polyposis CRC that accounts for 3% of all CRCs, and the salient feature include up to 100 colonic polyps. The lifetime risk of CRC in HNPCC is 80%, up to 50 to 60% for other cancer like endometrial cancer, and 1 to 13% for all other cancers. So familial and non-familial causes of colorectal cancer. So if we talk about syndrome with adenomatous polyp, that is APC gene mutation in 1% of the population, MMR gene mutation in 3% of population. Syndrome with hematomatous polyp in less than 1% of the population. Other familial causes up to 20 to 25% of colorectal cancer. Non-familial causes are personal history of adenomatous polyp, personal history of colorectal cancer, inflammatory bowel disease, ulcerative colitis, Crohn's disease, radiation colitis, ureterosigmoidostomy, acromegaly, Cronkite-Kanada syndrome. So this is the picture where we can see the familial adenomatous polyposis. The intestinal tract is highly overburdened with these polyps. Thank you.